Hello, I'm Dr. Beth Colby from Talk Mental Health. This video is a bit different. I'm responding to a comment a person made after watching one of my videos, one on tardive dyskinesia caused by antipsychotic medication. And this is what was written. Well, why in the hell would anyone prescribe these meds then? Horrible. What happened to first do no harm? That's a totally valid point, and I'll try and explain to the best I can why we do prescribe medication that can cause really horrible side effects. Doctors prescribe medication for physical or mental health problems, and we need to weigh up the risks and benefits of the medication and discuss this with the patient, because it's a collaborative thing with doctors giving information that a patient may not know, and then discussing with the patient and the patient deciding what they would like to do. With mental health, if somebody has a lack of insight into their mental health problem and they're at risk of harm to themselves or others, or their own health deteriorating to a massive degree, that we need to take responsibility for them and do things in their best interests. So for instance, if somebody is under the Mental Health Act, say because they've got a psychotic disorder and it is felt that they need treatment for this psychotic disorder and they do not believe they're ill, they do not want to be in hospital, they do not want medication, they don't believe they need it, but they're detained under the Mental Health Act for their own health, safety or safety of others, then doctors can prescribe medication and patient be given it against their wishes. We need to weigh up the risks and benefits. We still need to explain everything to the patient about why we're prescribing it, what the medication's being prescribed for and what we're hoping it will achieve, and also explain any side effects and answer any questions a patient has. And this will be an ongoing conversation. After somebody's been prescribed medication for 3 months under the Mental Health Act, then we need either the patient to consent to medication, and a T2 form, it's called, will be completed, and the doctor will write that they've explained the nature, purpose and likely effects of the medication, and that the patient has the capacity to and has consented to the medication. Or else if they don't, then a second opinion appointed doctor who doesn't work for the same mental health trust will be organised, and they will come and see the patient, look through the notes, speak to 2 non-doctors, 2 members of the multidisciplinary team who are not doctors. So for instance, a nurse and a social worker, or a psychologist and an occupational therapist, and discuss with them what their feelings are about the patient having that medication. And of course they'll talk to the patient about the medication and their experience of being on it. And then they write quite a lengthy summary of the patient's mental health, their mental health history and their mental state, and what the patient's saying about whether they want to have medication or not, or can actually understand what the medication is for. So if the patient has not got the capacity to consent to medication or is not consenting to medication, then a T3 form, it's called, is used. And on the form, it will say the classes of medication that the responsible clinician wants to prescribe. So they may want to prescribe an antipsychotic and a mood stabiliser, for instance. So that will be put on there. And also they may, every now and then, it's called on the PRN side, as necessary, as required, put say diazepam, which is under the class of anxiolytics, and might put that down. So everything's recorded, what class of drug, how many of them in which class that the responsible clinician is wanting to prescribe, and that the second opinion appointed doctor has agreed to. Because if the second opinion appointed doctor does not agree, then the responsible clinician will not be able to prescribe it. So that is a safeguard for the patient who has not got capacity to consent or is not consenting to taking medication. Now, with this particular example of antipsychotic medication and tardive dyskinesia, it's a horrible side effect, and we have to explain what we can to patients. Sometimes they may be so thought disordered that we can't explain anything, but as much as we can explain of what side effects may occur. And then, of course, if we think that somebody's, really seriously ill and that they're in danger of really harming themselves or harming somebody else, or that they are so deluded, for instance, that they're not able to enjoy any quality of life because they're so scared, or they're not looking after themselves, not eating, then the benefits, i.e. getting a patient well, would outweigh any risk of movement disorders from the antipsychotics. And then as we review patients, there are side effect scales for antipsychotic medication. So we look at them regularly to see what side effects the patient may have and discuss that. And we regularly review the dose of the medication. Are they on the correct class of medication? And are they on the least amount of medication that would do the same benefit? So it is something that we do regularly look at. One thing as a psychiatrist that I get really upset about is how much some patients put on weight with some of the medication that we give. And I've been not working for the past 3 months, but then did on-call last night to cover the junior doctor's strike, and saw one of my patients who I hadn't seen for 6 months, and he's clearly put on weight. And it's really sad to see that side effect, but he is so much better in himself that the medication is of benefit to him, even though he has put on this amount of weight. So all the time we're weighing up what's best for the patient and discussing it with them. And we monitor weight, we monitor people's HbA1c to assess for risk of diabetes, blood pressure, heart tracing, prolactin, which is a hormone, liver, kidney. So there's a whole heap of tests that we do to monitor somebody's medication, as well as explaining it to them and doing side effect scale. And we need to make the information accessible for patients. Like some of my patients have got learning disabilities, so we have pictures as well as a few words explaining things in simple language, and they're given a copy of the information so we can look at it themselves. Another accessible way is somebody watching a video and somebody talking about something rather than having the written word. Then of course we need to think of any patients who are blind or deaf and make all information for them accessible, and our speech and language therapists are great at helping us do that and making accessible resources for us to explain things to our patients. Just to summarise, everything must be in the patient's best interests. If they're not consenting or haven't got the capacity to consent to medication when they clearly need it, then a doctor will make that decision on their behalf. But within 3 months of being prescribed the medication under the Mental Health Act, then the second opinion appointed doctor comes in, who also assesses the capacity of a patient and whether they're consent or not, and looks at all the treatment plan, the drugs that the responsible clinician has written up, and writes that all down, writes a very lengthy report. The second opinion appointed doctor also speaks to 2 other members of the multidisciplinary team. And then, of course, the patient can have a mental health advocate, and they've also got their own mental health solicitors, as well as friends and relatives can speak and advocate for them and speak on their behalf and advocate for them. But it's not a them and us situation, because we're on the side of the patient as well. Thank you for listening. I hope that's been interesting. If you've got any other queries, please put them in the comment and I'll see what I can do to answer them. Thank you. Bye then.